I always tell men and women that menopausal women and men have a much easier time with fasting and if we really think about fasting as this hormetic stressor, it's a beneficial stress in the right amount at the right time. I think what we see on social media, what we see in terms of clinically with patients are people doing the extremes. Like
Of
if a
course.
little bit of fasting is good, more is better. So I'm going to fast. I'm like a 35-year-old woman that's metabolically healthy, and I'm going to fast, every single day, every time, every day of the month. And I'm going to wonder why I lose my menstrual cycle, or
Right.
I wonder why I'm suddenly incredibly tired and depleted. And so I feel like the amplification of voices to help people understand when to fast, when not to fast has really become a mainstay of a lot of the work that I do.
Cynthia, it's good to see you.
Absolutely. I've been looking forward to this conversation.
Well, you've had the pleasure, of course, of having me on your podcast, I think now 2 times. That sounded very egotistical, but it was a lot of fun to be on your podcast talking about methylene blue and hyperbaric oxygen therapy and all the other things that I do. And you have such a great platform and all the work that you do. And I know that you have your book that you've already published, and you have another one coming out in a little while. And you're a clinician yourself. You have a background in, the crazy worlds of ICU and clinical medicine like I do. So with all that sort of as preamble, I'm really happy to have you here and welcome.
Thank you. Thank you. I think we have bonded over shared experiences in Baltimore and, our trauma backgrounds, medical trauma backgrounds and ER medicine and ICU and sick, acutely ill patients. So.
Yeah. Well, then thankfully, there are good people that are still doing that work because it's not easy work, but it's necessary work. But I know your world has transformed because of, the fasting that you've described in your own personal life and how it kind of came around for you. And so I wanted to start off with, how did you first understand fasting and sort of the evolution of it? Maybe like a short story, and how that worked, just to give people like a framework for you on how that affected you personally. And then, from there, I'd like to talk about, like the major differences in men and women versus in fasting and how that really looks, in real time.
Yeah, I mean, I think my evolution towards fasting or my interest in fasting really came out of a personal desire to understand what was happening to my body in perimenopause. Like so many women, so many clinicians, all the information that we're dispensing to patients suddenly doesn't work for us. And we realize we need to do something different. And I always credit Jason Fung's work. I came to his work and it really gave me the ability to understand that there's real science behind intermittent fasting. It's not new or novel. And so about 10 years ago, I started intermittent fasting for myself just to lose stubborn weight that I suddenly was unable to get rid of in perimenopause. And then at that time, I was working in clinical cardiology, and I started to realize most of my patients have lifestyle related issues because of the frequency with which they eat, what they choose to eat, how little they're physically active. And so I started integrating some of it into my work with those patients. I would say maybe about 20% of them were open to the idea of eating less often. But it then kind of bled into this desire to really focus on lifestyle as medicine. And so 9 years ago, I left clinical cardiology, really started a practice solely focused on women in perimenopause and menopause. And then fasting at that time really became quite popular. And so we kind of springboarded from there to, developing protocols for women specifically because women are not small men. And as we both know, there is a rhythm to most women's lives until they go into perimenopause. And I was able to kind of ascertain how to effectively utilize this strategy with women at different periods in their lives. And I always tell men and women that menopausal women and men have a much easier time with fasting and if we really think about fasting as this hormetic stressor, it's a beneficial stress in the right amount at the right time. I think what we see on social media, what we see in terms of clinically with patients are people doing the extremes. Like if a little bit of fasting is good, more is better. So I'm going to fast. I'm like a 35-year-old woman that's metabolically healthy, and I'm going to fast, every single day, every day of the month. And I'm going to wonder why I lose my menstrual cycle, or I wonder why I'm suddenly incredibly tired and depleted. And so I feel like the amplification of voices to help people understand when to fast, when not to fast has really become a mainstay of a lot of the work that I do. And then also quite frankly and transparently, allowing people to utilize the strategy could be a right strategy at one point in your life and not in another, and
Hmm.
helping people understand when to use this hormetic stressor and when to back off a bit. And unfortunately, as you know, we live in a pretty toxic diet culture, and there's a lot of outside influences. So patients come into our offices or come into opportunities to work with us, and they have wildly unrealistic expectations because what they see on social media is sometimes not entirely real or sustainable, most importantly.
Hmm.
And so
Hmm.
helping them find out, like, what are the things they can do for sustainable long-term health that are not going to cause metabolic derangement, thrash their adrenals, their thyroid gland,
Yeah,
lead
yeah.
to losing their menstrual cycle, etc.
Yeah, well, that's a beautiful overview, I think. And maybe before we get too into it, there's a lot of, I think, nuances when people define the word fasting. And so there's water fast, I mean, back in the early bulletproof days, there was fat fasting, if you remember this. And that was a big thing. You could have fat, but you couldn't have any other macronutrient or micronutrient, just fat. There's obviously no water fast. These are what are called dry fasts.
Mm-hmm.
Maybe you can define some of these for people, just terminology, because we talk about intermittent fasting. That could be intermittently fasting for 20 hours a day, or if it could be for less. So maybe defining some of those terms would be helpful. Before I want to get more into like the sort of female centric aspects of this, but maybe that's a good place to start.
Yeah. So when I think about water fasting, it's helping people understand that when you are in an unfed state, you are hydrating your body with water, sometimes with electrolytes. I usually encourage that.
Hmm.
And that is what I think is the safest way of intermittent fasting, because in a dehydrated state, there are a lot of metabolic things that can happen. And in some instances, if patients are on blood pressure medications
Sure.
or diabetes medications, that can be problematic. On the other hand is dry fasting, which I know that the extremists in this space really like to focus in on. And there are specific benefits to that. And if you're a purist, you won't even shower because your skin will then absorb water.
I haven't heard
Um,
that. Interesting.
yes,
Okay.
yeah, the
Yeah.
purists, and then most others that are less of the purists, maybe they are just not consuming liquids of any kind during the period of time in which they're not eating.
Mhm.
And you can get some upregulation and autophagy, but I'm not a fan of that. I think my background in cardiology has assured me that hydration is an important process in our bodies.
Sure. Sure.
And then, yes, Dave Asprey very astutely, bulletproof coffee, fat fasts. I think when I have patients that are coming from a standard American diet who are eating 6 to 8, 10 times a day, the thought of eating less often is terrifying.
Hmm.
And I always looked at fat fasting as a band-aid approach to help them get to full water fasting. And so
Okay.
what might that look like? They may have some coconut oil or MCT oil. If you really want to get nuanced, like there are a lot of people that will say, well, if you put butter in your coffee, it's insulinemic because it's dairy. So then you're encouraging people just to stick with ghee, which is clarified butter.
Sure. Sure.
But I think for some people who need it's almost like a set of training wheels while they're learning how to fast. I think fat fasting can be helpful. I think the challenge that I sometimes will see is patients go overboard because, of course, butter, ghee, MCT oil, delicious, right?
Yep.
A lot of people go overboard. And if they're trying to lose weight, they're not cognizant of the additional calories. And fat, we know, is a much more caloric macronutrient. So fat fasting has a place. I always say for some people, it's like having a meal while they're fasting because they have so much fat in the coffee.
Hmm.
And I think that certainly can have a place. But I tend to be someone that thinks of fasting as like, keep it simple, don't overthink it. And that's where I think hydration and water fasting is a much better option. I've had much greater success when patients get to a point where they are solely water fasting. And that could be for 15, 18, 20 hours. The challenge then becomes, helping people understand, like, what are you fasting for? Are you fasting so that you can get on social media and say, hey, I haven't eaten for 48 hours? Or is there a specific purpose? Are you someone that's trying to heal from an autoimmune condition? Are you, just trying to kind of dial in on some of the strategies that you're utilizing to utilize excess stored fat as a fuel
Hmm.
source?
Hmm.
There's a lot of different ways to look at it. But when I look at it as a whole, water fasting is generally what I'm speaking to. And those other two caveats, there are people that still embrace it. But I think you have to just be aware of the pros and cons of each. I think always with dry fasting, I would end up in most instances having people that had, their HRV would tank, they would be, clinically dehydrated, their heart rate was up, their HRV was down. So clearly their body's showing some signs of
Huge amounts of
stress and
stress.
strain.
Yeah.
Right.
Yeah.
And
Yeah.
so again, goes back to that hormetic stressor, right amount,
Right.
right time, not at altitude. I probably wouldn't go to Denver and dry fast. That probably wouldn't be good for me.
Especially if you're not used to being in the dry weather. Not
Correct.
a good idea. Yeah. Yeah. It's funny. The dry fasting, the other name for this group of people, if they're like spiritual, is the breatharians. Have you heard of this before?
I have not.
The breatharians are people that they can get all that they need nutrition from the air. So they get the prana, the energy from the air, and they don't need water. They don't need food. So like that's another group of fasters from like the spiritual side, if you want to call it that. When you're talking about intermittent fasting, Cynthia, you're talking typically within a 24-hour period. I mean, and then what's your sense of just like broad strokes? We'll talk about this more when we get to more female centric, but like as far as like longer fasts, is there a role for 3, 5, 7, 14, 21 day fasts or is it more that you found that from a clinical perspective, people can get most of the benefit doing some realm of intermittent fasting in your experience?
Yeah. I mean, I think it always comes back to like, what is the reason for why people are doing it? I think that I would just say if someone is lean and metabolically healthy, when they start getting over the 24 and 48 hours, I start getting genuinely concerned about the catabolism of muscle. Muscle is so precious. So there's that camp. But then if we look at 92 to 93% of Americans are not metabolically healthy, most of us can benefit from a degree of not eating. And so that's where I like a 2 to 3 day fast. I know that there are people out there that, I want to fast for 5 days because I want to stimulate stem cell activation. And I know that I need to fast that long for that to happen. Or I get someone who will say, I'm willing to do a medically supervised longer fast. They want to do 21 days, 14 days. And that really, in my estimation, really does need to be medically supervised.
Right.
Not meaning that you have to be in an inpatient, but that you do have to be seen and evaluated by your provider. And so I think when I think about fasting, I like to think about it more in the shorter experiences because I am just so conscientious and concerned about preserving muscle. And we know after the age of 40, sarcopenia just really starts to kind of upregulate. And so from my perspective, I like the shorter fasts, especially for those that are already lean. You and I should not be doing 7, 14, 21 day fasts. We would whittle into nothing.
Yes.
But I do think that there is a time and a place for longer fasts. And specifically if someone is, how many patients I've seen who are post-cancer treatment and they really want to dial in on.
I was thinking cancer treatment. Yeah.
Correct.
Cancer. Yeah. I've seen that
in conjunction, with their oncology team.
Right.
I think there's very specific circumstances, but again, I'm so myopically concerned about maintaining muscle that I try to be very cautious and judicious about the length of the fast for the patient.
Yeah. I mean, you said a couple of things that just ring true for me. One is like the extreme part of it, right? So people like the commoditization of all different these dietary fads or the non-eating fad, as it were, right? That you get sort of the fads around that, which can be dangerous, right? I remember like in the keto movement, going to a metabolic health conference, Dom DiAgostino is a friend, he's a good guy, but I was like keto pizza, keto ice cream. Like, this is like 4 or 5 years ago. That's what kind of like the heyday of like keto and fasting. But I had a lot of concerns, as you do now, and I did then, with muscle mass and people that were on the lower end of the spectrum of weight doing these longer fasts or even doing intermittent fasting, just not getting enough calories in on a day-to-day basis. Did you see a lot of that happening initially, and has there been an evolution now, or what is your sense of that? Because I mean, I certainly don't recommend as much fasting as I did initially when this first came out.
Yeah. And I mean, I very transparently last year, I lost my dad. And one of the things that contributed to his death was this profound, significant sarcopenic frailty that led to falls, which led to a couple head bleeds.
Sure.
And so that made such an indelible impression on me. Over the last several years, I've been doing much less fasting, but now I speak very openly that for me personally, I do a lot less fasting and I eat an additional, like I was eating 2 good meals, but now it's 3. And I'm really, I probably take more women off of fasting than I have before. And definitely over the last 2 to 3 years, explain to them like, this is still a strategy you can use. If you go on vacation and you overdo it, you come home, you want to kind of get back on track, or, maybe you fast 1 or 2 days a week, but helping them understand that the greater good is that they really, again, have to be myopically focused on maintaining, preserving, and building muscle. And the only way to do that is you've got to strength train, and then you also have to eat adequate amount of protein. And so I find for a lot of women, there's this duality. We've been conditioned to believe that we want to be skinny. I grew up in the 80s, and that was certainly is the fat phobia,
of course.
Fat-free cheese, all sorts of disgusting things that we ate because we were so fearful of fat. And the realization that we were conditioned to believe like small is better, skinny is better, and having to kind of reacquaint patients and clients with the understanding that what we really want to ultimately be is strong. And the only way to be strong is we have to feed those muscles, and we need to lift, and we need to stop being so restrictive. Because one of the things that I saw, quite honestly, Scott, was there's definitely this minority of women that would hide their eating disordered behavior in the guise of fasting. There's some of that.
Yes, sure.
And so kind of whittling that out when I was working with people. And then now we also have the concomitant use of GLP-1s. And so we see this overlap where there's still this emphasis on, being thinner, being smaller, but helping people understand, like, in order to remain as independent as possible for as long as possible, you have to maintain your muscle.
You have to be strong. Yeah. And that's the thing.
Be strong.
Yeah.
So
I mean, our ancestors, like they had to carry things for long periods of time. They were skinny, but that's because they were getting just enough nutrients to be able to do the things that they needed to do, like carry water from a river that was 3 miles away or something like that. And I appreciate that I know you've had this evolution. You and I have spoken about it on your podcast when I was chatting with you about how that's changed over the years. Now, when you're thinking about fasting in these various stages of a woman's life specifically, whether they're having their normal periods, or they're perimenopausal, this is kind of when you came into it versus menopause. Maybe you can kind of go through how you approach, what's your framework as a clinician when somebody comes in, and I know this probably has to do with their goals to some degree for sure, but there's also probably some general frameworks that you use here to really kind of help people along. So maybe you can go through what those are a little bit per 8 different age groups, and that'd be interesting.
So I kind of divide women into 35 and under, so still peak fertility age range. If they're metabolically healthy, I'm not going to be encouraging them to do a lot of fasting. Like 12 to 13 hours of digestive rest is great. If they are metabolically healthy and lean, only a little bit of fasting if they choose to in their follicular phase when estrogen predominates.
Okay.
Versus if someone is 30 years old, 25 years old, they're PCOS, pre-diabetic, or even type 2 diabetic, then again, just in that follicular phase, helping them understand that a little bit of intermittent fasting a few days a week would have tremendous gains, even if it's 2 to 3, and helping them understand like what that looks like. It doesn't mean that they binge on the other days. It means that they're kind of drawing in and getting very purposeful, very focused on those 2 or 3 meals that they can fit into a feeding window, and then not fasting during their luteal phase when progesterone predominates. And it's interesting, if you look at the research, the week preceding a woman's menstrual cycle, she might need an additional 125 to 150, 175 calories. So that's not the time. That's actually when women will say, yes. Yeah, okay. They'll actually say, oh my gosh, I feel like I could eat everything and anything. And it's like your body is thinking that it may actually be producing a human or creating a human. So it's looking for a little bit more food source. So that's women under the age of 35. I always look at the guise of, are they metabolically healthy or not? Because that allows me to kind of determine how aggressive do I want to be. Now, perimenopause, 35 to 50 for a lot of women, some people on the earlier side, some on the later side. Again, it goes back to where are they in their menstrual cycle? How are they doing in terms of metabolic health? Are they starting to become insulin resistant? Have they gained 15, 20 pounds? And this is something we need to look a little more closely at. It also ties in with women become less stress resilient as they are navigating into perimenopause. Sadly, as our progesterone is decreasing, our cortisol is one of the few hormones that goes up. And so helping women understand, like, we have to really think about the hormetic stressors in our lives. And I find a lot of women, if they latch onto fasting, they're probably someone that also wants to do infrared sauna. They want to do cold plunges. They want to do high intensity interval training.
They want to do it all. Yeah.
They want to do it all. And I respect that, because I love all the technology. I love all the wearables. I love all the things, but it has to be the right strategy at the right time. And so if they're not sleeping through the night, I don't want them fasting.
Totally.
And they do 12 to 13 hours of digestive rest. Absolutely. In fact, my teenagers can do that, and they're 6 feet tall and 175, 190 pounds. So they can not eat for 12 hours, which says a lot. So it always kinds of go back to if you're foundationally not managing your stress, not sleeping through the night, adding in fasting is not helping you.
I love
But they
that.
can certainly benefit. They can certainly benefit from 12 to 13 hours of digestive rest. And then as we're kind of working through things, it's always the lifestyle as medicine piece first before we even talk about HRT, before we even add in a GLP-1 or anything like that. Again, focused on that follicular phase if they want to take advantage of intermittent fasting, not in the luteal phase. And then women in menopause, there's so much more flexibility because their hormones, for the most part, unless they're on HRT, are relatively flat. It's like a little bit of a flat line as we navigate menopause. And so it goes back to the same thing, though. If you're not sleeping through the night, if you're going through a divorce, you just lost a job, you're doing a cross-country move, it is not the time to add in like 18, 24 hours worth of fasting. And I think that's a message that more women need to hear because many women come to fasting thinking that is the be all end all that is going to fix all of their problems. And what they actually need to do is less. And that is very, very hard for high functioning women like myself. I had to learn that the hard way. Sometimes doing less is actually going to be better for you than doing more.
I love that. Yeah. In fact, I was just on a podcast and they asked me about anxiety, right? And people trying to work with anxiety. And I said the exact same thing. And it's kind of a similar frame, which is that it's not like you need to do more to become less anxious. You need to become less, you do less to become less anxious. And the same thing goes here because a couple of things kind of came to mind as you were talking. One thing is this stress component, right? You're talking about if somebody's not sleeping well, if they're like lots of stress already. And this is where I'm just interested in your navigation, right? Because bringing in intermittent fasting is stressful, right?
Yes.
But if you have somebody that is metabolically unhealthy and they have PCOS and they're 25 years old, that you want them to start intermittent fasting 3 days a week, how do you navigate that? Is it? I mean, because you just start off with really small window, like a big window, and you kind of you slowly sort of decrease the window from there. Or how do you think about it?
Sometimes it's like training wheels on. For some people, it's okay. We're going to not eat for 12 hours, and that blows their mind. Okay, well, we're going to have a tablespoon of MCT oil in your coffee because you love coffee, and you're going to go to the gym. Let's add that. And we literally will do a 30-minute increment. Like we go from 12 hours to 12 hours and 30 minutes to 13 hours. And then, I'll say like, let's try to get up to 15, 16 hours. And sometimes that's where I think the fat fasting can be helpful. But if I know, and we know at the basis, like 3/4 of the women with PCOS are of the phenotype that they genuinely are either obese or overweight. And so doing just about anything is going to be more beneficial than doing nothing. I think, it's the number one endocrine disorder in the world. And yet it is so poorly diagnosed, understood, and addressed. And so at the basis is inflammation, oxidative stress, and insulin resistance. And so for me, it starts off with low-lying fruit. Like, what can I get them to do? Maybe they're not going to change their diet much. Right. But we're just going to compress their feeding window and I'll see if I can get them to eat a little more protein.
Yeah.
Like baby steps.
I love that. Yeah. With Dr. Ted, one of our founders, he always, that's kind of something that he, I think, pioneered a long time ago, even like 10 years ago or so, where he would just shorten somebody's eating window or feeding window, whatever you want to call it, instead of having them change anything. Like you're not going to change your diet. You don't have to change anything you're doing. Just eat for less amount of hours and then slowly incrementally decrease the amount of time that they're eating. And then when they're ready, start changing their diet too.
Well, and it's amazing to me that we as clinicians, like we walk into a patient's room or they're sitting in our office and we're like, there's 95 things I want you to do. Yeah. And when I kind of struck out on my own 9 years ago, I would put down the 95 things I wanted them to do. And I slowly started to realize maybe 10% of my patients could actually do that. And so now I'm like, here are 3 things I need you to do. And it's like simple, straightforward, like don't focus on all the other. It's very easy to get distracted and overwhelmed, especially when, there's influencers and people on social media that are spouting nonsense, as you and I both know. And Indeed. So now I get very nuanced. It's like, I want you to track your macros and eat 30 grams of protein at each meal. And then they're like, that's a lot of protein. I'm like, well, you need more protein. Or, 12 hours of digestive rest. And I want you to go to bed 30 minutes earlier. Sometimes it's that small.
But granular, right? So giving them like actionable things, but in a small way that can make a huge difference, right? Like I always like the example of Cornerstone Habits that was created. Charles Duhigg, I think, wrote a book on this a while ago. And like a cornerstone habit he described there as exercise. Once you start exercising, everything else gets easier. Like once you start seeing something happen from a metabolic side and in these patients, right, you just have them go to bed 30 minutes earlier and all of a sudden they feel so much better. Like that gives you the window to do more, right?
Yeah. And I think it's really important because we have to meet our patients where they are. That's ultimately what it comes down to. Like when I think about the patients I've worked with where we've had tremendous success over the years, it's because they're ready and we capitalize on the fact that they are ready to make those changes as opposed to, generationally, I'm sure you've seen this. You had patients that were of a different generation and you could literally just spoon feed whatever needed to happen.
Yep.
Younger generations are not that way. And so, they want a much more kind of interactive discussion, which I think is great. But they don't want to be spoon fed. They're like, I want to understand, help me how to get from point A to point B and how to do it successfully so that I can sustain this. Because ultimately, isn't that what we all want? We want sustainability as opposed to like a quick win so that they then, they peter out in a couple months because they're like, I can't do this forever.
Yeah. I have a question for you. It's kind of a side question, but it's related. Do you have your patients or clients coming in after they've consulted with ChatGPT for like 7 to 10 hours on an issue and then saying, this is what ChatGPT needs me to do or thinks I should do? What do you think? This is happening to me all the time now.
Yes. In fact, I had a woman today who was prescribed a GLP-1 by someone else who said to her, I don't know how to prescribe this drug.
Okay.
To the patient then read that to be, oh, I get to decide how I take this medication. So she went to ChatGPT.
Yeah.
And so when I had a conversation with her, I said, you want to lose 40 pounds. You are not going to lose 40 pounds dosing tirzepatide at 1/10 of the initial dose.
Okay.
I was like, it's not going to happen. And she's like, but ChatGPT. And I was like, ChatGPT is not a medical professional. And I'm telling you, you are not going to get what you want at that small of a dose.
Yeah, I've just been seeing, I mean, I know that there's a new model just came out, but the sycophantic aspect of ChatGPT is very, 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 you have to be very careful, at least previously, right? Because it would just tell you what you want to hear. And that's dangerous. And so I have a couple of my patients that will email me these like list of things that they put all their supplements and all their data and everything in ChatGPT, and this is what they wanted, and this is what they're doing. And I'm like, dude, this is not the way we practice. We got to, but I mean, I think it's good on some level because you do have a lot of empowerment for people, but then like, there's so much more data for people to go through. It's not like going to Dr. Google back in the day and like, I have a hangnail. Oh, that means you're going to die. That's typically what the final conclusion about anybody was going to be. But before I get to GLPs, because I want to ask you about those. One thing that you did mention earlier on menopausal women and HRT. So if you said, obviously during menopause, the hormones are flat, but if you're going to put somebody on HRT, how does that change your calculations as far as what your perspective would be, Cynthia? I know there's not a lot of people on HRT, but more people are getting on it. So just interested in your framework there as well.
Yeah, it's a great question. So 5% right now is what we believe to be in the United States on hormone replacement therapy. So you're correct. It's a very small subsect of the population. What's interesting is when I do intake paperwork, I know who's on HRT because they sleep better. Like that's a given. Sure. Like they sleep better, they manage their stress, they generally are having less libido issues. So to answer your question, I think that if a woman comes to me and she is on progesterone and estrogen and testosterone, and maybe she's on pregnenolone, DHEA, and a few other things and feels great, and she's sleeping through the night, then I'm like, yeah, I mean, and you're managing your stress, you feel good, then yes, you can add this hormetic stressor.
Right.
More often than not, it's the opposite. It's someone who hasn't slept well in 5 years. They've gained 50 pounds. They're now insulin resistant. They've got fatty liver. They haven't slept well, so they don't eat well. They don't exercise because they're too tired. And so I think that, when I'm looking at that subsect of the population, it really is viewing it from like a bio-individual approach. How is that person perceiving? Like people can say they don't feel well, but then everything else, all the other metrics that we look at look pretty good. And I think that on a lot of different levels, it's viewing each one of them as an individual. But the consistent patterns that I see are people that are on HRT are generally doing better.
Yeah.
The funny thing is, every time my team and I post anything around HRT, 99.9% of the comments are positive, but we always get I'm 56 And I am the same weight I was when I was 16, and I feel great, and I sleep well, and I have a great sex life, and this whole thing, but I'm not on HRT. And why are you going to make me get on HRT? And I'm like, well, first of all, you're not my patient. And second of all, if you understand physiologically what's happening beneath the surface, I said, I hope that you and your clinician sit down together and they talk to you about shared consent, about what the possibilities are if you are not on HRT for bone, brain, heart benefits, all those things, metabolic health. I said, and after you've had that conversation, if you still choose to not be on HRT, that's obviously your choice. But what I imagine is happening is your clinician doesn't want to talk about HRT. And the only information you're getting is from social media. So you're getting, in some instances, like a very biased perspective. Because I look, again, it goes back to those quality of life metrics. Who wants to remain as independent as possible? And certainly from my perspective, when I look at family members, now my mother's generation were all taken off of their HRT post WHI, Women's Health Initiative. And so when I look at all of them, and I have permission to talk about this publicly, the neurocognitive effects of being off hormones for the length of time that they have been off of them doesn't sit well with me. And so that's the stuff that I think about is maybe at 56, you don't see those effects, but at 70 and 80, and if you live long enough, older than that, you will.
Right. And we know that women live longer, but they have less higher risk. They have a higher chance of having poorer quality of life in those later years, right? And they have a higher chance of dementia as well if they do live to a certain age compared to men. So I think that there's a lot going on there and I appreciate your perspective. And I've had a number of, I know you speak to a lot of experts in these kinds of fields too. And my wife's 47. So like we think about these things a lot in my house too. So it's all it hits home, for me too, and so one thing that I think that gets talked about a lot during when you're doing intermittent fasting and you are as a clinician kind of working with patients is looking at various metrics, biometrics, data, laboratory values. And some of the things would be kind of obvious, but like that would be interesting in your take is, you have to make sure people don't like drop out their blood sugar if they start losing weight fast. But there's other things like the one that I always think about that was one of the first ones on the women's side is like, if you fast too much, you're going to screw up your thyroid and you're going to mess up your thyroid hormones and you're going to fuck up your metabolism. So maybe you can just address that piece and then, because of your experience and you can talk about the different walks of life when women's different stages, maybe through that. And then maybe some of the other biometrics that you're thinking of that are kind of ones that you found to be most important as people are kind of going and starting to do more intermittent fasting.
Yeah. I mean, I always think about thyroid as, is it the chicken or the egg? Because it's so common to see latent hypothyroidism or subclinical hypothyroidism in middle-aged women that my question is always, was it there before or did fasting just bring it about? Because I don't have a patient right now that is not on thyroid replacement.
Really?
Not one. Now, granted, I mean, I work with a very specific population of women, whether I've started it or another clinician has started it. But I think in many, many ways, it's what I would say to anyone. If you have newly diagnosed hypothyroidism or Hashimoto's and you still are exhausted and your hair is falling out and you're constipated and you feel bad, then it's not the time to add another hormetic stress. Now, if you're stable on thyroid medication, your labs look fine, that's different. But when I'm looking at lab metrics to see what have I seen clinically from over fasting, high reverse T3, and I know many clinicians don't necessarily draw that or believe in it. I will see depressed free T3. I will definitely see, beyond the or even elevated antibodies. Beyond that, cortisol issues, you'll see a serum cortisol, and I know a serum cortisol is not a 24-hour circadian distribution. Right. You can see blood sugar lability. I definitely have seen a lot of and it's probably also concurrently going on with heavy menses. And so they've got low ferritin and, their percent SAT is low and their iron levels may or may not be problematic. But I'm usually looking at the other metabolic markers, like what's their fasting insulin. Like I had a woman recently, her fasting insulin was 1. And I said, that's not that's a little bit off. It's not even like it's high, but, looking at fasting insulin, looking at other metabolic health markers like C-peptides, A1C, I don't always see that being particularly helpful. Looking at a 2-hour postprandial glucose to see how well they're doing, looking at CGM data, looking at Oura Ring or Whoop band metrics, like HRV to me is really important. And I help people understand like this is a good sense of sympathetic to parasympathetic
Right.
balance in the autonomic nervous system. I mean, those are the things that I'm generally looking at, but I also listen, as I know you do. I really listen to what they're telling me. Like, can you get up in the morning and not feel like you need 5 cups of coffee? If someone's telling me they're drinking a lot of coffee, they're, drinking a lot of alcohol at night to wind down, more often than not, there's some degree of dysregulation of multiple factors. But latent hypothyroidism, subclinical hypothyroidism is such a huge problem. I rarely see Graves, but I feel like, and I know there's been a lot of talk about the FDA recalling a lot of these desiccated thyroid products, which has got the whole thyroid community in an uproar because that would impact a lot of people. I just think there's a lot here that I didn't know before I left clinical cardiology, how many women were impacted by subclinical hypothyroidism. And when I say that, these are people that are slowly brewing, developing a hypothyroid state, and in many instances feel a whole lot better on medication, even at low doses. But I think in many, many instances, it comes down to like just being a good detective, like taking a good history and then adding in the labs to be able to say to the patient, hey, your cortisol's very low, and we're ruling out other things that could be going on. Let's get a circadian distribution of salivary cortisol so we can see what you're doing throughout the day. I think that can be helpful. But those are typically kind of broad strokes, some of the things that I'm looking at clinically.
Yeah, there's a big uproar, maybe 5-7 years ago now, regarding women fasting and causing thyroid dysregulation. So, but it seems like your take on this is that there's a time and a place like everything else, right? Like
right. I mean, it can be helpful for mitochondrial function. Right. I mean, that's the big thing is that I remind people if your thyroid function is stable and you don't have symptoms, that's an opportunity where you could utilize intermittent fasting as a strategy. But the opposite is also true. Like if you are very symptomatic, you're not stable on medication, that is not the time to add more stressors to your body. And I think for a lot of people that are so desperate to lose weight, again, we go back to this weight piece. They're so desperate to lose weight, they're willing to do just about anything and they'll just fast longer. And I'm like, that's actually making it harder for your body to be able to do the things it needs to do. And when we talk about a broken metabolism, I don't feel like that's so much specific to intermittent fasting. I think that's part of the diet culture where people have chronically calorically restricted for years and years and years. And they've gotten themselves down to eating 600 calories a day. That's where I think food diaries and chronometer or chronometer, depending on who you talk to, I think are really invaluable because sometimes I literally have to say to people, you are eating 600 calories a day. You're telling me you're not hungry. I'm telling you that is not sustainable. Your body thinks you're starving.
Starving mode. Yeah, there you go.
And then we have to go through the process of slowly adding food back in and doing it in a way that doesn't trigger, again, like latent eating disorders in many instances. They freak out about the scale.
And also massive weight gain too, right? Yes. Because if you're under sort of that starvation mode, your body is trying to keep every calorie it can. I had a good friend of mine who did a long fast, like a 14 or 15 day fast. He's the kind of person that doesn't have a problem fasting. But after that, he had a really hard time losing weight because his body just went through like survival mode. And then everything that he tried to eat afterwards, like didn't matter what it was, he would gain more weight.
Yeah. And I think it's something I'm incredibly sensitive to. I feel a tremendous responsibility because, God, the universe gave me this opportunity to talk about fasting. But I feel like it's really important as a clinician and as a middle-aged person to make sure that I'm saying to patients, like, I think we're getting into a point where you're chronically undernourishing your body, and that's a problem.
Yeah. And I saw this like time and time again, a number of years ago, people doing too much. But one thing that came to mind as you were talking is, do you have a preference in general if people have breakfast and no dinner versus having lunch? Because I can just say personally, like I do much better not eating throughout the day and having a bigger breakfast as opposed to having no breakfast or nothing to eat until 1 or 2 o'clock in the afternoon. And then I just want to gorge because I'm starving. Yeah. So I don't know what your sense is here, but I've talked to Dom D'Agostino about this actually too. And Dom, for those that don't know, is a keto researcher for years and years. He's been fully ketogenic for like over a decade, or at least. He was one of the first guys talking about this from a non-medical perspective back in, I guess 2000, I want to say 14, 15, that time frame. And so do you have, I mean, and what he'll tell me is he'll have like a big breakfast, but then he won't eat the rest of the day. And then maybe he'll have like a light dinner or something like that. But his biggest meal is typically breakfast. So just interested in your thoughts on meal timing and circadian biology and things like that.
Yeah, no, I'm a big believer in eating earlier in the day. So I think that that's much more in alignment with our insulin sensitivity as well. So I will say to patients, have a good sized breakfast, 9, 10 o'clock in the morning. And then, maybe you're eating a second or third meal later in the day. I feel like when patients eat a bigger meal earlier in the day, they tend to eat less food the rest of the day.
Yes.
It also sets up better blood sugar regulation. In many instances, they're not binging. I think many patients for a long time were doing the opposite. They were going to the gym at 5 o'clock in the morning. They were doing something intense. They go to work. They drink a couple of cups of coffee. They would like squeak through till lunchtime. Then they would eat a decent sized lunch, and then they'd binge in the afternoon. They'd have candy bar. They'd have soda. Then they would get home, and it would just continue all throughout the evening. So what I have come to find personally and professionally is I think women in particular do much better having a bolus of protein in the morning and then kind of going about their day. Now, how people decide to make it, if they decide to have a protein shake and some other thing, that's one thing. I mean, I like to have a real meal in the morning, but I think that protein bolus is really critically important. And it's also kind of setting you up for muscle protein synthesis and everything else that comes from that. It also ensures, I find for a lot of people that if they get a good sized meal in that the rest of the day, it's less important what else they eat, but that first meal is the most important meal of the day.
Yeah, protein intake is a big part of it. And you're mentioning already in various ways of protein. And you mentioned the word bolus, which I love from our hospital days. We call it about bolusing fluids, bolusing food. Bolusing just means like having your meal, like having a substantial part of something at that time, right? So bolus, for those that don't know what that means. But from protein perspective, it sounds like you've evolved here significantly. What is your sense for women and protein now and how that evolves through the life cycle too?
Yeah, I mean, I think that protein is the way. Protein helps with satiety. I mean, there's so many mechanisms that get triggered in our bodies when we consume adequate protein. And I probably have no less than 50 to 60 grams in a meal. Like I've worked my way up to that. But when I'm looking at food diaries or chronometer, what I find is women are eating like 50 grams a day. And really what I want them to be focused on is 100 grams a day minimum.
Yeah.
Even making the argument 1 gram per pound of ideal body weight. So I'm consuming 120 grams a day. That's ideally what I'm trying to aim for. Now, when patients weigh more than that, they're like, that sounds insurmountable. And I said, well, it doesn't mean you go from 50 a day to 100. It means each time you sit down and eat, it's an additional ounce. Like you need to understand what 4 to 6 ounces of protein looks like and adjust accordingly. There's no shame if you're in a restaurant. Like I went to a restaurant this past weekend and I was like, I want the 8-ounce filet. And even though that's how much it weighs before it's cooked, but still, I'm like, I want the bigger steak. I definitely want to be pushing the envelope because more often than not, when you're pushing those protein metrics, it means you're having some vegetable with that. Maybe you're having some healthy fat, depending on what the meat or fish or poultry is. But I find that people tend to do a whole lot better. It's when we don't eat enough protein. And there's this protein leverage hypothesis, which I'm sure you're familiar with. But for women in particular, as we are navigating perimenopause and menopause, as our follicular stimulating hormones going up and our estrogens going down, it really triggers this. If you're not getting enough protein, guess what happens? Your body's looking to make up for the lack of calories. That's why you end up in your pantry at 7, 8, 9 o'clock at night looking for more food. You're hungry. You're genuinely hungry. And a lot of it has to do with you haven't triggered that threshold of protein intake over the course of the day. And you're probably eating chips and ice cream and, cookies and things that are not ultimately going to be the macronutrients that allow you to build and maintain healthy muscles. They're going to contribute to more subcutaneous or even visceral fat. And it's helping women understand like there's a way to eat that's going to help facilitate maintaining as much muscle as we can for as long as we can.
Yeah. And that's really the key, right? Is kind of balancing these metabolic metrics that we have and understanding also that sarcopenia kills people. And unfortunately, it sounds like, your dad, right? And I listened. I was actually had a researcher on here a long time. Her name is Lucia Aronica. She'd be good for your show
Yeah.
as well. She's an epigenetic researcher. She did this study called the Fit Fat study and looked at various dietary changes and epigenetic changes and like, but in the end, like looking at epigenetic, these new clocks that we talked about, right? And how you can game one of the clocks by going completely vegan for 6 months, your epigenetic age is going to increase, but then your muscle mass grows down like 20%. And she talked about her mom who was in her 80s. She's like, I would never want my mom to do this, even if it extended her lifespan, because what about her health span, right? So I mean, I think that's really what this comes down to when it comes down to your evolution with this, especially this emphasis on protein.
Yeah, no, I think what's interesting to me is when I reflect back on different stages of my life, even when I was, in working in ER or still doing a lot of hospital medicine, what do healthcare providers do? They're oftentimes never able to, let alone empty their bladder, let alone eat. So what did I sustain myself on when I rounded? I would have like crappy protein bars and bottled water, and that's what I would be drinking all day long. And I always say, like, ultimately we have to mimic the kind of lifestyle that we're recommending to our patients. We actually have to live it ourselves. And I kind of cringe when I think back to those days where you'd sit in the doctor's lounge and be, jamming food down your throat as you're getting
fast
paged.
as you can, fast as you can. Yeah. But let's change gears a little bit, because I wanted to also get into GLP-1s a little bit, because I know this has been a big hot topic now, but I know you've been speaking about it more. So I guess, what do you think about this whole realm of GLPs? How are you using them in clinical practice? Which ones are you using for which types of people? Maybe go into some of that and we can kind of explore some questions.
Yeah, I mean, I would say right now exclusively tirzepatide, because I found that it is, there's less side effects. With Ozempic, semaglutide, there was a lot more nausea. And then I would get so much pushback about the nausea. And I'm like, I get it. You don't want that. No one wants that. But tirzepatide for women in perimenopause and menopause that are looking to shift body composition, when we're already working on foundational elements, let me be really clear.
Sure.
Most of them are wanting to shift body composition, and I'm 100% supportive of that in conjunction with, HRT and other modalities. Then there's another group of women who are, maybe they're almost at their ideal body composition, and they've either got autoimmune conditions, maybe they've got inflammatory conditions, like rheumatoid arthritis is one that really stands out. They deal with chronic pain. And this is where I think I find GLP-1s to even be more interesting. People that are trying to reduce cardiovascular risk, maybe they have terrible heart disease in their family. They themselves have no evidence of heart disease. Their lipid markers are all dialed in, and they're just trying to lessen the likelihood of developing atherosclerotic cardiovascular disease. And so this microdosing concept, what is microdosing? I think it probably depends on whomever you speak to. Maybe it's 25%, maybe it's a tenth of a starting dose. It's well tolerated. They're not looking to lose weight. And so this is where, this nuance related to GLP-1s that I find so fascinating. I think that what I find kind of looking at how other people are practicing, or things that I'm seeing in the on social media in particular, it's like the wild, wild west. So I try to be really specific. If I'm choosing to prescribe this, number one, you have to promise me you're going to strength train. And number two, you have to be really conscientious about your protein intake.
Right.
Because the GLP-1 is useless if you end up losing significant amount of muscle mass. And that is that's why we do pre and post bioimpedance readings, so we can look at like your fat-free mass, to your muscle mass. And then they also can objectively look at them themselves. And it allows us to kind of track, for transparency purposes, what are we actually losing? If we're losing body fat, great. If we're losing a significant amount of muscle mass, then that's concerning. And then that tells me you're probably not doing the first two things that I asked you to do. So that has become part of every discussion that we have with patients, just helping them understand how important it is to maintain that muscle mass. And I feel like I harp about this, but I've been able to see this from the inside out, both with my patients and then also personally with a family member. I think that's that very slippery slope of sarcopenic frailty that we don't think about until, grandma goes into the hospital and can't get off the bedside commode. But I've seen 50-year-olds with that same issue. And so if you want to remain independent and you're choosing to take a GLP-1, those are the two things I require my patients to do. Now, what I find is most of my patients don't necessarily have to get to therapeutic doses. They're getting improvement in some instances. They're on a, 2.5 or 5 milligrams, and they're doing really, really well. And they don't ever need to get 10 or even larger doses. that I know other colleagues have had to use with some of their patients. So I think that it's encouraging.
Mm-hmm.
And I think, to me, I feel like I can't think of another drug in the trajectory of my experience working in the medical field that has had the kind of impact that this has the potential to have. And I'm also not of the belief system that patients should be shamed.
Okay.
I see a lot of that on social media, and it's not a cop out. I don't look at it, when a patient says to me, this is the first time in my life I don't have food noise. I'm not thinking about the pantry. I'm not thinking about the chocolate. I'm not thinking about alcohol or any other, food that is their kryptonite. They're like, I just don't think about it anymore. And this has been like, if but nothing else, this has been the greatest achievement I've ever had in my entire life when I have been burdened by food noise my entire life. And I think that is, that is what I think is really fascinating about the drugs themselves. And even, we know that the second generation GLP-1s have that GIP as well as the GLP-1 agonist. So I think it's really interesting when the more we understand and the more applicability that we'll be able to utilize. I think it's like we used to joke about this in cardiology, and I'm embarrassed I'm going to admit this out loud. We used to say that we needed to have benzodiazepines and statin in the water supply because we could make a justification that everyone needed one. I cringe when I say that now, but I think we will get to a point where there will be, if people choose to take a GLP-1, there's probably going to be an indication that will help them.
Yeah, well, I think we would have been better putting LSD in the water supply than statins and benzos. But I can see that from a cardiology perspective. Yeah. Right? Like everybody thinks. I mean, you mentioned some really interesting things there. I think one of them was related to alcohol. And I know that we're seeing a lot of potential with these microdosing protocols. Again, there's a lot of variability what that number is or how much of the percentage that you're taking, but for addictive behavior too, right? Mm-hmm. So, and have you seen that in clinical practice too?
Yeah. And I think that's what I find fascinating. Like people have said to me, because we do talk about alcohol, and I speak very openly that I think, alcohol is one of these things that we don't speak enough about the potential harm of alcohol use. And I see a lot of women that depend on alcohol to like unwind, and they're stressed and they don't sleep well, and then they wake up with the alcohol. And so that's part of the educational process, is just making them aware. I'm like, I'm not here to judge. I just want to make you aware. And they'll say, oh my gosh, you know what? I don't need those 3 glasses of wine at night anymore. Yeah. And that to me is incredibly encouraging. It's like this untoward side effect that they didn't expect, but they're thrilled. They didn't realize they actually were drinking too much until they started a GLP-1. And then those kind of addictive behaviors are just blunted.
Yeah. I mean, what's your sense here? There's some feelings that it's very similar to the Sackler family kind of deal, right? Because once you get somebody on these drugs,
it's hard to get them off.
You got them for life. And that's exactly what pharmaceutical companies want, right? Which is a drug that you love, that's blockbuster, as it is with the GLP-1s, but you can't get off of. And what's your sense of that? Like, how do you, because I haven't done this a lot in my personal clinical practice. I'm not prescribing them typically yet, a couple people, but not very many. So how do you feel about that in general?
I mean, I think we have to explore that with the patient. Ultimately, I think what I'm hearing, and I'm hearing this from clinicians too, that are taking GLP-1s. I will take this till the day I die because they feel like I'm going to microdose this because I feel so good, whether it's pain or blunting their hunger response or, allowing them to maintain whatever body composition they want. I think it's meeting people where they are, and it's asking them, we could titrate up and we can titrate down and see where you are. I think there are technologies that are kind of evolving. There's a company that I'm interviewing the CEO this week. And it's a company that actually has a bitter melon extract that apparently does the same thing. If you look at the research, is very effective. I myself am just learning about the technology, but are there things we can do to help patients successfully come off these drugs if they don't want to be on them long term? I get the sense that most people don't want to be on them long term.
That's my sense too. And most people do actually stop taking them, right? Yes. That's the natural history of these things, that people do stop them. And I know that there's these new evolution of supplements and drugs that are coming out that are oral. And that's my sense too, is there's going to be this transition from people taking the sub-Q and then finding these oral alternatives that may not be as strong, but then have a similar effect. And that can maintain using some oral GLP, peptides or oral GLP, bitter melon or whatever it might be.
Yeah. And I think, the other thing is I feel like for a long time, especially on platforms like X, where it could be, it's like the wild, wild west, people have very strong opinions. And I'm like, listen, if you were on the ground listening to what patients and clients are telling you, you will understand that this is not, I do not perceive GLP-1s as a crutch. I really see them as, in many instances, miracle opportunities for patients who have not been metabolically healthy
Right.
suddenly start reversing disease. And then, to be in a position where they're able to be more active and sleep better and engage
Right.
with their family. And so I look at it
Right.
as a win-win, as opposed to, I've heard clinicians, I've heard people talk about how, it's a cop out, it's a shortcut. Like, I don't feel that way. Maybe because I'm more pragmatic. I'm like, listen, in the greater good, if we look at how our population's health is as a whole right now, something needs to change,
Yeah, I mean, and I don't think it's not our fault. I mean, the people's fault, right? In the sense of
Mhm.
just the type of culture, the food culture, the big agro, big farm, like everything is sort of against you in some ways of making you try to eat more calories than you need, of hyperpalatable foods.
Yep.
And so it's been kind of like an interesting wake up for some of these other companies, right? That have to like, have you heard of these the companies are trying to make GLP-1 friendly foods and friendly snacks to get
Yes.
people to start snacking again too?
I know. And I think, I understand there's a marketing piece, there's a
Yeah.
desire to generate revenue, but I also think we've never held these companies really accountable.
Mhm.
And, we have a whole generation of people that, is it 70% of people, they eat ultra processed food all the time. And it's like they
Yeah.
don't know what real food tastes like. And so, I think that, I don't know. I mean, there's no quick fix. I mean, that's not what I'm saying. There's not one or two things that are going to
Sure.
change the way that we choose to feed ourselves. But I also think that there could be no greater thing that could occur if suddenly these processed food industries, if they started losing money because people suddenly were just not hungry to snack.
Well, that's what's
I mean,
happening, right? And that's
yeah,
what's actually, that's one of these, the impetuses or the why they're trying to come out with these
junk
GLP-1
food.
snacks, that you can have, and
It's
that's kind
called
of
no.
it's
It's
called
called
no,
no.
it's called please no, but
Yeah.
that's the nature of our that's the nature of our just how our system capitalism, right? Um, Well, Cynthia, so I want to transition a little bit. I want to ask you some rapid fire questions as we're
Okay.
reaching the end of the podcast today. These should be fun. You can take, 10, 30 seconds or a minute if you want. Um, and yeah, you ready? You
Yep.
excited? Okay, here we go.
I'm
Okay.
excited. I am definitely.
Okay. All right. So first question. Number one health myth you'd wish would disappear forever.
Oh, um, one of my biggest pet peeves is that it's just calories in, calories out.
Yeah,
Like people think
that's a
it's
big
just
one.
about the calories. It makes me crazy because it negates the fact there's so many other things that contribute to weight gain, including hormonal dysregulation.
Yeah, it's a great one. I 100% agree. Um, what is a health gadget you actually use every day?
Oh, I love my Aura Ring. I'm a data nerd and I like quantification. So I like to look at my HRV and, how much deep sleep I got and how much REM sleep I got. So yeah, I would say without question that, or I really like my Apple Watch because I like to track how much steps I've taken during the day. It's no surprise. Like I'm very left brained. I like to track things.
Cool. I love it. I have my Aura Ring too. Although I have some friends of mine that are telling me that I should get the Whoop instead. I don't know. I haven't tried
I
that one
haven't tried
particularly.
it.
Yeah.
I'm reticent to make a change because I like my Aura Ring.
I like it too. How long have you had the Aura Ring for?
Oh, like 4 years. Like I probably have 5. Like I've had every color, every finish, and then as they start dying, I get another one. Yeah, it's crazy. I've had every finish you can imagine. Like silver, gold, yeah, everything. Rose gold. Yep, I've had everyone.
Nice. I dig it. Okay. Next question. What one health, so try again. What one wellness habit you think is overrated?
Cold plunges.
Ah, that's what I thought you were going to say it. I know that. Why?
Cold plunges. And it's not because I don't see the value in the hormetic stressor. I think that it's very bio individual. And I know there are people that being in a cold plunge will raise their cortisol more than they need. So it just puts you in a position where if we're already dealing with high cortisol issues, maybe you need 30 seconds of a cold shower and that's all you need. So again, it goes back to that amount of hormetic stress. And I just see women that are white knuckling it through a cold plunge. And I'm like, dude, go do cryo or go do 30 seconds, at the end of your shower, do 30 seconds of cold water. And I think you're still getting benefits, hormetic benefits.
I love that. I'm a big fan of not cold plunging in the sense that I think
that would be my hell.
I don't mind it. I think it's good, but I think it, like everything else, like you mentioned early in the podcast, like people just overdo it, right? Like overdoing, yes, one cold plunge is good, but why wouldn't 7 be better, right? It's just the American way, right?
Well, it's women that say like, I want to have 15% body fat. And, I'm like, you're already lean. You're like very clearly, very lean, very fit. How much benefit are you getting from it? You're probably causing more cortisol derangement than need be.
Yeah, I'm 100% with you. Okay. One more question, or maybe two. If you could only give one piece of health advice to your younger self, let's say you're 20 years old, what would it be?
Oh my gosh, I would have told myself to sleep more. I think I spent my 20s like not sleeping much. And I was an ER nurse and I worked nights and we would work, 3 or 4 night shifts in a row. And I would sleep more because I probably needed more sleep.
Yeah, we had, I think maybe I mentioned this on your podcast, we had shirts in medical school as medical students that said sleep is for quitters.
Yeah.
So it's not a good culture that we,
No, it's like self-flagellation. Like I don't sleep enough. So I'll pick up that other 12-hour shift.
I just want to show everybody how tough I am and how much sleep I don't need. Yep. I guess on the other side of it, what are some non-negotiables when it comes to sleep now?
Oh my gosh. Generally speaking, in bed before 9:30 or 10, cold, dark room, thermostats at 65.
That's cold.
Yeah. And my whole family's used to it. They like to blame it on me, but I'm like, everyone sleeps better, which is what we found. I would say, just being off electronics. If something is stressing me out, I like have a piece of paper, I'll write it down just so I don't perseverate over it.
I do the same. Yeah.
I used to say no, turning off Wi-Fi, but I can't do that now because I have teenagers and it's like if someone needs to reach me, I need to be accessible. But I would say those are probably the very boring things that I think are super sexy. I would say the other thing is melatonin and inositol. Like what are the things that I think help me personally sleep?
Yeah.
Melatonin and inositol, progesterone forever, magnesium, those things are super helpful.
Yeah, I love it. Well, this has been great, Cynthia. I really appreciate you spending time with us here. I have one more question for you. This is what we ask at the end of our podcast all the time. It's, the podcast is called Smarter, Not Harder. You've given a lot of great advice, a lot of great frameworks here, but what are 3 ways that you'd recommend everybody can live smarter, not harder, given all of your experience for all the different walks of life as a clinician, as a parent, as a wife, as whatever else? Just what would you think would be some of the good kind of takeaways for people?
Yeah, I would say number 1, hydration is far more important. I see so many people that chronic dehydration is driving their HRV problems. It's driving their energy problems. So hydration and electrolytes go a long way. I would say do something that brings you joy. That oxytocin release that we get from being around loved ones, pets, people that we enjoy spending time with. A hug goes a long, long way to lower cortisol. Oxytocin's an underrated hormone. And I would say
I don't think it's underrated, is it? People don't know about it, maybe.
It doesn't get enough respect.
Yeah, I agree. It
doesn't get enough respect. And so we look like crazy people. We have 3 dogs in our house. So we're constantly hugging furry animals. And
that's a lot of dogs.
Occasionally when my teenagers are willing to give hugs. I would say number 3 is creating more boundaries. I think that one thing that I have really worked diligently on the last few years is getting very clear about what is acceptable and unacceptable in my life. And that includes people. So having healthy boundaries is another underrated thing that I think if more people had healthier boundaries, they probably would live very differently.
I love it. Yeah. Dr. Ted, who I work with, likes to talk about toxic stress being toxic people too, right? So got to get those out of people, get those people out of your life as well. So that's beautifully said, Cynthia. So, well, thank you for being here. Tell us where we can learn more about you, your platform. You have a great podcast, your books. Give me all the stuff.
Thank you.
Yeah.
Probably easiest just to go to my website. So it's www.cynthiathurlow.com. You can access to Everyday Wellness, which is my podcast that Scott's been a guest on twice and a very popular one as well. I'm active across social media. I am most active probably on Instagram, a little bit on Facebook and a little bit on Twitter, although be forewarned, I can be a little snarky. We also have a YouTube
okay, good
channel.
news.
Yeah. I grew up in New Jersey. It's deep down, it's there. We also have a YouTube channel that we're slowly growing. So we put our full length podcasts on there for everyone to see. But if you reach out, definitely let me know how that you listen to the podcast, and I'd love to connect.
Well, again, thanks so much for being here, Cynthia. I wish you the best rest of your day, and good luck with the teenagers, the dogs, and elevate that oxytocin, right? I'll try to do the same over here.
Absolutely. Thanks,
Take
Scott.
care.